Hi everyone, my name is Emma Klamala. I'm an RN and I recently also graduated with my Doctor of Nursing practice. Today I'm presenting on a project that addressed food insecurity in patients with type 2 diabetes, titled Implementation of a Food Insecurity Screening and Resource Protocol in a Type 2 Diabetes Population. To give some background, managing type 2 diabetes requires a comprehensive approach, including medication, psychosocial support, and diet. However, food insecurity, which is common among patients with type 2 diabetes, can severely hinder disease management. When patients can't access nutritious food, it becomes more challenging to follow dietary recommendations and to control their diabetes as a result. Despite the high prevalence of food insecurity in patients with type 2 diabetes, food insecurity was not routinely screened for. Additionally, staff had limited knowledge of local food resources, and referrals to these resources were not consistently made. The purpose of this project was to develop and implement a comprehensive protocol that integrated a validated food insecurity screening tool and a referral mechanism to connect patients to local resources. This project was implemented at one endocrinology clinic within an academic medical system in a Midwestern city. To address the issue, we took several steps. First, we conducted semi-structured interviews with local food pantry and food prescription program leaders to understand the challenges that food insecure patients face. We selected the Hunger Vital Signs screening tool, which was integrated into visit notes for type 2 diabetes patients. We developed online training modules for staff to ensure they were prepared for the new process. During a 6-week pilot study, dietitians administered the Hunger Vital Sign, provided referrals to healthy food pantries, and connected patients to ambulatory care management when additional support was needed. Focus groups with staff and chart reviews helped us evaluate progress, and we adjusted the electronic health record system to track the data more efficiently going forward. Now, taking a look at the results, local food pantry leaders did share key barriers for food insecure patients, which included high grocery costs, long distances to grocery stores, limited availability of culturally familiar foods, and difficulty finding resources independently. 2 local food pantries offering fresh, healthy food did accept referrals to their programs. However, a food prescription program faced budget limitations and could not accept referrals at that time. We also created a workflow with ambulatory care management to facilitate direct referrals when further assistance or other social determinants of health needs were identified, such as housing insecurity or transportation. During the pilot study, 68 patients were screened total. 17 of them, so about 18%, were identified as food insecure and were provided with resources. 4 of these food insecure patients, so about 24%, were also referred to ambulatory care management for additional support. And the resources that they were provided with per the new protocol included the 2 healthy food pantries as well as a list of pantries by zip code. When we gathered feedback from staff, they did mention challenges with adhering to the Hunger Vital Signs script, as it was sometimes awkward or uncomfortable. They did identify some discomfort in screening certain patients due to the fear of offending them and also time constraints that led to inconsistent implementation at times. Food insecurity is a significant issue among type 2 diabetes patients and affects their ability to manage their condition effectively. Understanding this impact is crucial when designing any sort of intervention. The screening and referral protocol did meet goals for staff satisfaction and workflow integration. Stakeholder discussions confirmed that the protocol aligned with their objectives, such as avoiding major workflow disruptions and also maintaining accreditation with the American Diabetes Association. Looking forward, we recommend advocating for comprehensive social determinants of health screening beyond food insecurity. This could include housing security and transportation, among others. It's important that these screenings align with clinic workflows, however, to ensure that they are practical and sustainable for staff. Collaboration with local healthy food pantries did help address some of the challenges patients faced, but the limited capacity of these programs highlighted the need for ongoing partnerships, resource advocacy, and active fundraising efforts. These are crucial for sustaining and expanding the program's impact. There is an opportunity here to evaluate the impact of food programs on diabetes management and to further assess how referrals to all food pantries affect patient outcomes. This could provide valuable insights into how we can improve patient care and access to resources. A few recommendations we made were to update the training modules to reflect some revisions that were made and to advocate for the comprehensive social determinants of health screening and to have this integrated into the clinic workflow as part of future initiatives. Thank you so much for listening, and email me with any questions.